All right, thank you all for joining us. Sending a warm welcome to everyone here. So today we're here to learn about current research taking place in the community services sector. Our guest speakers will be sharing their research on topics including children and young people, emergency outreach responses, health and disability. Speakers will share a 15-minute presentation including the scope and methods, some of the findings and the impact of their work, with time for questions during and after the session. I'd like to begin by acknowledging the traditional owners and custodians of this land, the oldest continuing cultures, diverse languages, and knowledge holders in human history. I am joining you from Meanjin, Brisbane, and I respectfully acknowledge the Yagara and Turrbal people and all First Nations colleagues and friends online in the webinar today. For those of you online in the meeting today, please feel free to join us in acknowledging country where you are today through the chat function. So for the agenda of today's session, we'll have the presentation from our first guest speakers, followed by a Q&A. We'll then have a quick 5-minute break before moving on to our next two guest speakers and then another Q&A. We'll finish with a poll and sharing upcoming events. A couple of things to note, by default, you will be on mute, but your camera will be turned on. This session will be recorded, and the recording, along with a copy of the slides and resources, will be shared in the post-event email. If during the session you'd like to ask a question, you can write the question in the chat function. If we run out of time, we can follow up with you individually after the session. Just pop your question or comment into the chat pane. As the world of AI is ever evolving, there is an increasing potential presence of AI bots like Read AI in our webinars. The presence of these bots can potentially lead to privacy concerns by harvesting information and distributing session content. We will stay vigilant in removing these bots from our meetings, but ask if you see an AI bot or shared material to please let us know. So it is now my pleasure to introduce our first guest speakers for today's event. First, we will hear from Toni Sumner and Dr. Jemma Venables. Toni is the team leader of Brisbane Emergency Response Outreach Service, BEROS, a service supporting young people in out-of-home care who are self-placing. Dr. Jemma Venables is a senior lecturer of the School of Nursing, Midwifery and Social Work at the University of Queensland. Jemma's research explores the policy practice interface in child, youth and family practice, with a particular focus on transition from out-of-home care and the intersection of statutory systems and non-government support services. And then we'll hear from Adjunct Associate Professor Leonie, who is a dental practitioner, academic, researcher and owner of Seniors Dental Care Australia and Oral Healthcare Training and Education. So I will stop sharing. Jemma?
That's showing for everybody?
Yes, thank you.
Amazing. So, Toni, will I let you take us away?
Sure, I can kick us off. Thanks for sharing the screen, Jemma. Thank you, everyone, and thank you for the introduction, Nadia. So I'm Toni. I'm the team leader of BEROS. Today, we wanted to talk to you about how we've engaged young people considered to be high risk in research about their lives. So let's get going. We first would also like to acknowledge the traditional owners of the land on which we meet and work. So for UQ and BEROS, Jemma and I work across Turrbal and Yagara lands, and BEROS also extend up into the Sunshine Coast region. So we work across Yugambeh, Jinabara, Quandamooka, Waka Waka and Gubbi Gubbi country. So we'd like to pay our respects to elders past, present and emerging. I'd also like to acknowledge the overrepresentation of First Nations young people and families in care and justice systems. So today we're going to give you, hopefully stick to the 15-minute limit, but Jemma and I can both talk about this for days on end, so please help us stay in line. We'll briefly touch on who BEROS is and what work that we do, and the program of research that BEROS and UQ have been working on over the last few years. We'll talk briefly about how we've been able to engage young people in the process, Jemma will speak to the overview of findings. I'll give you a brief rundown of how we've managed to integrate those findings into BEROS practice, and then Jemma will talk you through next steps in terms of what research is coming up next.
So in terms of setting the scene for this program of research, but also importantly, the work that BEROS does, the cohort of young people that we're talking about are young people who are in out-of-home care, so in our child protection system in various placements. But this is a cohort of young people who leave those placements without approval to stay in other unapproved locations. So that's in Queensland often referred to as self-placing, and young people might be living in locations such as couch surfing or living with family, friends, partners, even strangers, and may even be sleeping rough on the streets. Other terms that are commonly used to talk about this in the international literature are terms like AWOL, absconder, runaway, escapee, missing. So we can hear a really deficit-based discourse when we're talking about this cohort of young people, and also a really strong institutionalised narrative and almost leaning into a criminalised element when we start talking about absconding. So this is a cohort of young people who have already experienced disadvantage both prior to entering care, often have really difficult times whilst in care, and then are further disconnected from the system and supports when they're self-placing. So a really important cohort of young people to be supporting and learning from, so that we can make sure we've got better policies and practices in place to make sure they've got the best chance in life. So just let Toni explain a little bit about what BEROS does and who they are.
Yeah. So BEROS, as Nadia said, is originally termed Brisbane Emergency Response and Outreach Service, but we've now expanded up into the Moreton Bay and Sunshine Coast region. So some people like to call the Sunshine Coast version of BEROS SCAROS, which we don't really like the sound of. So BEROS is just the catch-all term that we're still using. Anyway, I digress. So we support 12 to 18-year-olds in the care of child safety who are self-placing. We're funded by the Department of Child Safety, but BEROS is actually managed by a community organisation called Community Living Association based in Nunda. We have contracts and work alongside child safety service centres in the Brisbane, Moreton Bay and Sunshine Coast regions, so specifically supporting young people who have an order that sits with those service centres. But lots of those young people are quite transient and move between those regions. So we're lucky in the sense that we can be flexible and responsive for, a Sunshine Coast or a young person with an order in the Sunshine Coast who's actually self-placing in Brisbane. Our model is a 24/7 response model. So we've got outreach-based case managers who work from 9 to 5, Monday to Friday, doing one-on-one work with young people to meet their goals, whatever they might be. We have an assertive after-hours outreach team, which is in partnership with microprojects. So microprojects run the Street to Home service. But we also at CLA run the overnight support and emergency accommodation. So we have 3 houses, one in each region, which has 2 beds for young people to come and stay where they don't have an approved placement and maybe they need a break or a bit of a respite from their self-placing arrangement. Maybe they're between placements, lots of reasons. Yeah.
Thanks, Toni. So I've been in the really fortunate position of being able to work alongside BEROS on a program of research since 2018. And that started off with an evaluation of BEROS because it really was a pilot program that originally came out, I guess, of recommendations from the Carberry inquiry back in 2013. And so there was no real model like this. So our first part of sort of this research journey was doing an evaluation of BEROS in 2018. And we were really lucky that that led to not only a report that was shared with BEROS and also the department, but also journal articles and conferences being able to talk about this model. And importantly, the impact of that was that some of the findings helped to inform the expansion of the service, as Toni said, from beyond Brisbane to further up the Sunshine Coast. And we were really excited that some of the findings that I'll talk to in a moment about what young people value in a service was taken on board by the department and led to the introduction of a new government funding stream where organisations could be funded to provide more outreach support in recognition of that was how connection was being made with young people who were self-placing. We couldn't expect young people to turn up to service centres and so on. We needed more outreach models, and luckily we've now got a funding stream that facilitates that. that as a result of some of the research we've done. In 2022, we were able to expand the research to include not only BEROS, but also the voices of the department as well, through a pilot study that was funded by UQ. Again, I'll talk in more detail exactly about what we did and some findings there, but just in terms of the implications of that research, again, been in the position to have international journal publications, international conferences, the development of resources for young people and also for practitioners. And excitingly, the voices of young people that we captured through that, I was then able to share at various department forums and the really recent residential care review, including the roundtable and expert panel. And we're excited that because of this sort of momentum that we've gained, the partnership with BEROS and the department, we've then been able to join with others, including the CREATE Foundation, so a leading body for the voices of young people in out-of-home care, Uniting Care as a residential care provider, and the Queensland Aboriginal and Torres Strait Islander Child Protection Peak to undertake a much larger 3-year project that will look at this issue across the entire state, not just in the southeast corner. So how did we get young people to take part? Because their voices is the absolute key to this program of research. And I'll let Toni talk about how we've worked together to engage young people in the process.
Yeah. So really it was about coming together with the research team from the start. So working with them around the research design process. So for us, coming together as a team, you know, talking to young people, really bringing together the themes that they were coming to us with over and over and over again. So making sure that some of the topics that were going to be explored in the interview felt relevant to the young people. So they weren't just coming in and sharing their stories for something that felt like it didn't actually connect for them. So making sure it felt like it had purpose. Also working with them alongside around the recruitment material. So making sure when we were taking information out to young people to explain the project, that it was in ways that they could understand and get behind. Obviously it was voluntary, but making sure that there were multiple ways for young people to take part. So it wasn't that you sign up to an interview and then you have to go to the university to meet with a researcher you've never met before and tell them your life story. It was actually about how do we make this accessible, and knowing from our model of outreach, having the research team come into spaces that young people felt comfortable with. So they could either have an interview face-to-face, they could talk over the phone, they could just do the case file review, making sure that there was a lot of focus on building relationships and trust with the researchers. So we had the research team come out to the BEROS houses where young people sometimes are, so they could meet. It didn't mean they had to commit to being a part of the research, it just meant they could put faces to names, they could ask questions, get to know them a little bit. Kind of, you know, young people are very good at reading someone's vibe, I guess. So making sure they could vibe with the researcher before they made that decision about whether they wanted to talk to them. So the research team would often come out to BEROS. Sometimes they would come at nighttime as well, after hours. Not all young people want to talk to someone at 9 in the morning. Often it's after, after 6 or 7 p.m. So the team would come in, they'd bring pizza and just kind of sit around, have a chat, have a yarn. We also had letterboxes at each of the houses where we had a list of all the researchers, their names and a picture, so they could see, if they did want to decide that they wanted to take part in the interview, they could kind of get a sense of who they might feel more comfortable speaking to, whether it be a gender issue or whatever. So that was really helpful. And then they could sign their forms in the recruitment material, the EOI, and put it in that way. And then really flexibility, so making sure that there was times, locations that suit young people. Again, phone, over Teams, face-to-face, either at the BEROS house or somewhere else in community. But not only that, having multiple opportunities. We work with young people who are living in survival mode. So yes, they might want to really be part of the interview process and the research process, but life comes up, maybe something's fallen apart at home, priorities shift hourly for a lot of these young people. So making sure it wasn't a one opportunity and you're done. Like, that didn't work out, let's try again next week. Let's try again next week. Let's try this way. Let's try a different time. So that flexibility really helped to build trust as well.
And I think as a result of that trust, we were able to hear really rich, honest, nuanced stories from the young people, because that trust had been built. And I think that speaks volumes to the findings that we've then been able to share and how we've been able to highlight young people's voices in this space. So just to speak briefly to the findings from the initial evaluation, so that involved 13 young people taking part either in a survey or an interview, and that was really focused on what were the elements of the BEROS model or a support model that made them want to engage. And so importantly for us, that sort of led to young people being really clear about accessible and responsive supports, that's got outreach, that's reliable and responsive. And that's the finding that I was talking to in the introduction that informed the development of the department's new funding stream for outreach services, this recognition that young people value this, and this is how we make sure they stay connected so that we can enhance their safety, connection and wellbeing. They need caring and trusting relationships with workers. They need support around having choice about their engagement, what their goals are, that really leans into that stage of life as well around their developing agency. And they need advocacy and support in navigating really complex systems, both the child protection system, but also how that intersects with housing, social security, the mental health and health sector, and making sure that there was workers there willing to amplify their voice, but also to help them with a roadmap of how do I even work within these systems, and that support being really central to their wellbeing while they were self-placing, but also transitioning into adulthood as well. In terms of the pilot study that we conducted in 2022, this was where we were able to speak to a different cohort of young people. So we spoke to 11 young people who were aged 12 to 18 in the pilot study. We also had focus groups with practitioners both from BEROS but also from the department as well. So both in frontline CSO roles, senior team leaders, senior pracs, and also members of the executive about what it's like for statutory officers to be supporting this cohort, the barriers, and then also BEROS talking about what it's like working as a voluntary service supporting this cohort. We also undertook case file review with the consent of young people to just see how their placement journeys and self-placing experience had been recorded by others. So from this work, we've been really excited and lucky to be able to share young people's voices in terms of how self-placing can impact their participation in decision-making when they're in care. Young people have a right to take part in decisions that impact their life, and we were able to really share some of the barriers to that when young people are self-placing and the disconnection that they've got from the child protection system. We've also been able to share findings about the challenges that statutory child protection practitioners face, due in part to the risk-driven bureaucratic environment that they're working in, and we were able to identify 3 different practice approaches, varying from very risk-adverse, another focusing very much on young people's independence, and another focused on relational practice. And finally, we've been able to share about how all of this sort of feeds into transition planning and support. So of those findings, we've sort of touched on some of these now, and I want to make sure we've got enough time for Toni to talk about how the findings have been integrated into the service. But I think the key message that has come through from young people is that the notion of choice when self-placing is complicated. Sometimes it's called they're voting with their feet, and it's as if they've got all the choice in the world, but sometimes that choice is made within a constrained environment where it may be the best of a bad lot of choices. So there's some nuance there that's important for practitioners to understand. The importance of relationship and the importance of practitioners being an advocate who can amplify their voice and walk alongside them has been the key message that comes through for us. So Toni, I'll hand over to you. These resources are something that have been developed from the findings in terms of being young people friendly, and Toni will be able to talk to how these resources that we've developed have been integrated into practice.
Yeah, thanks, Jemma. So yes, those resources have been really invaluable. We have a welcome booklet that we've created that goes through the service that we can give to young people, and we give to child safety service centres, so that when they're talking to young people about the option for BEROS, they can kind of explain what to expect. We've got those resources in there. We've got those printed up as posters in the houses for all young people, workers and other workers coming into the space to see and read. And we've got an event coming up in a couple of weeks where we've got lots of our departmental colleagues coming in, and the plan is to gift them their own posters so they can take it back to their offices. The other thing I think really importantly is in our recruitment processes that has shifted. So we've got those resources in the recruitment kit. So whenever anyone applies for a job with BEROS, they read through the young people's advice in terms of what they want, what young people want workers to know about self-placing. And then there's some key selection criteria questions that get applicants to speak to that. And then we follow that up in their interview. It's also integrated into our induction processes. It's in our procedure manual. And then in terms of our practice framework or our practice principles, where we've got that all articulated, we've pulled in quotes from the research that Jemma and UQ have done to really articulate how our values and our practice approaches are, I guess, felt by young people, or why it's important to young people. So it's not just this abstract term, it's actually showing, you know, this is how it works, this is why it's important. That's probably the quickest way to share that integration.
Thanks, Toni. So that's us really. As I said, we're really excited that we can continue this program of research, and within this next project, we're hoping to speak to at least 100 young people from all across the state, including in places where there is no BEROS and no specialist support, and also being able to look at the practice and strategies that child safety officers use in different geographical locations around the state, and how different communities come together to support this cohort. So we're really excited about what comes out of that space. Thanks, everybody.
Thank you, Jemma and Toni. We will save questions till after Leonie's presentation, so I'll pass it over to her to share her presentation now.
Thank you and good morning, everyone. I would also like to acknowledge the traditional owners of the land on which we're meeting today and give a warm welcome to Indigenous persons participating. The learning outcomes, I'm going to talk about a trauma-informed care approach, then talk about why oral health and general health are linked and so important. I'm going to describe a recent research project we've done in aged care, and that'll be the scope, methods, findings and impact. So first of all, I just want to assure people that this is a respectful and a safe place. And just the thought of dental, anything dental, makes some people anxious and nervous, and it can trigger further traumatic events. So just want to say that it is a safe space. If it's too much, please get up and walk around. I'm available to talk to after the session. Thank you. Now, there has been a lot of innovative oral health research, and I've actually listed here all the areas in which the research has been done. And you'll see here that probably this list is probably a lot of the areas that people who are participating in the webinar today are from. So it's very diverse. Infants and children, people with mental health issues, people with disability, substance abuse problems, but it's also now reaching out to integration with general health. So we've got projects with midwifery, diabetes, etc. Now, the importance of oral health. Why do I keep pushing oral health? It's really fundamental to overall health and well-being, and important for the person's quality of life. If a person has poor oral health, it's really difficult for them to eat, to speak, and socialise. And also we see that people are in pain, discomfort, and they have embarrassment. So for us, oral health is very important. Now, the link between oral health and general health, we know a lot more now about those links. And it's a two-way link. Poor oral health affects your general health, and your general health also affects your oral health. So We know that a healthy mouth may also help the prevention of other health conditions, such as heart and respiratory diseases, cancer and diabetes. Now, if not properly managed or treated, it has a really negative effect on lots of aspects of a person's life, and that includes their personal relationships, their self-confidence, as well as attendance at school and work and overall performance. For working in aged care, I also know that if you don't have what we call a functional dentition, which means enough teeth to eat or good dentures, it means that they have these people have fewer food choices. They're less mastication or chewing food, a poorer diet.
Sorry, Leonie, sorry to interrupt.
Yes.
Your screen isn't being shared at the moment. Could you just go ahead and reshare?
Sorry about that. I don't know what
something's happened. Yeah.
Thank you for letting me know. Is that right? Oh no, wait a minute.
Just impressed.
Yes. Oh, okay. Are we
Perfect.
right now?
Thank you.
Yes. Sorry about that.
Yeah.
Little glitch. Yes, so poorer diet and nutrition. People with poor oral health are also at higher risk of illness, hospitalisation and death from infection. And this is an infection like an abscess or a toothache. But it's also aspiration pneumonia and infective endocarditis, which is a heart attack. So by having good oral health, you're actually reducing the risk of those potential hospitalisations. Now, barriers to oral health care. A lot of people think, why is access to dental care so difficult to get? And there's all these reasons listed on this slide here. Medicare covers the whole body, but not the mouth. The only Medicare schemes for oral health are for children, and that's in the Child Dental Benefit Scheme, Veterans Affairs for people who have been in the Defence Force, and also cleft lip and palate. So apart from that, there is nothing that Medicare covers. Also, for people in the NDIS does not include funding for dental treatment. Aged and home care does not include funding for dental practitioners. We're not included in the Aged Care Act at all. State and territory public dental services only treat between 7 to 20% of the eligible population. Here in Queensland, they only treat 12% of their eligible population. And for those people on the waiting list, these waiting lists can be up to 2 years. Only 49% of people aged over 15 have visited a dental professional in the last 12 months for a checkup or for treatment. And in Australia, in 2022-2023, there are nearly 90,000 hospitalisations for dental conditions. So when it's really bad, of course, we end up in hospital. And quite often, because you can't go to a dental practitioner, people go to a GP or a medical practitioner, and this results in prescriptions for antibiotics or painkillers. That might be a good short-term fix, but it's not fixing the problem. There's also a shortage of dental practitioners in regional, rural and remote areas of Queensland and Australia. And people don't know who the different people are in the dental world. So they don't know the difference between a hygienist, an oral health therapist, a prosthetist, a dentist or a specialist, and they don't know who to refer to, when to refer or how to refer. And so with this list, I think we've got to look at how, if we keep going the way we are, nothing will improve. We have to look at doing things differently. Okay, so the social determinants of oral health. Oral health is probably the best example of social determinants of health. And it really is what we call the neglected epidemic, because even though virtually the whole population's affected, it is not a priority for state or federal governments, and that's in Australia and in other countries. We know that there's greater tooth loss for people with lower levels of household income and educational attainment. Low income is associated with greater severity of the impact of conditions on the quality of life of adults. And some populations are affected even worse than the general population. This is Aboriginal and Torres Strait Islander people, people living in regional and remote Australia, and people with complex and specialised care needs. And also people who are not having regular checkups miss out on that really important feedback and advice for their at-home care. Okay, so oral health literacy. We also find that health workers themselves, health workers, community workers and personal carers, they have a lower oral health literacy. We can't assume that they have good knowledge, skills and attitudes for oral health. And this is really one of the barriers in trying to improve oral health care, because many of the health workers, community workers and carers don't have that knowledge and skills. And some of them also have experienced dental trauma, and they find it too traumatic to actually do oral health care for another person, as it again triggers those traumatic events for them. And also a take home from today is when somebody goes to a dental clinic or a dental practice, the dental treatment they're having, whether it be fillings or extractions or something, that's repairing the damage from the infections of dental caries or dental decay or gum diseases. It doesn't prevent it. The way to prevent these dental diseases is what we call twice daily at-home care. And so that's why that at-home care that could be provided by community workers, health workers, carers is so important, because that's the care that actually prevents dental diseases and prevents the hospitalisations and possible death. So talking about our research project, we received $200,000 from ARIA, which is an aged care research facility at Flinders University in Adelaide. The partners were the University of Southern Queensland, Flinders View Nowlanville Aged Care, which is a Blue Care Uniting Care home in Ipswich, Oral Tech, which is Smilo.ai, and myself, Seniors Dental Care Australia. We hope to raise awareness and education and screening and referral using an artificial intelligence app called Smilo.ai for the residents in the safety of their own home. It's actually a mixture of artificial intelligence and human intelligence, because a dentist also oversees the digital photographs and checks on the oral health reports. These reports are available to the residents and their family members, dental practitioners. For the people who participated, the service was free. Okay, so how does it work? So using a mobile phone, the person, 3 to 5 photographs using the mobile phone are taken and put into the app. That's a front view, side view, top teeth and bottom teeth, just using the phone, nothing extra. That goes in. And out comes a report where different areas, you can see here, different areas of decay or gingival problems are actually highlighted on the photographs. This happens in about 3 minutes. Smilo is approved, TGA approved, and all the data is kept here in Australia on Australian databases. This is an example of the oral health report. I know it's too small to see, but it actually gives a rating in green, orange and red. So good needs attention, or red, it needs urgent attention. And it also gives information about dental diseases and some information about at-home care. Now, how did we go at the aged care home? The people were aged, we had 41 people were actually screened. This data is just for 37 of those. The people were aged 71 to 99 years, average age 84. Of the 37 included in this data, the other 4 are in we just couldn't access at the time that we gathered these. 10 of the 37, or 27%, were green, so no issues. They just needed a routine dental checkup. However, 32%, that's 12 of the 37, were in the orange category, and they needed a clean. So it was either the teeth and gums or the dentures, and these photographs are photographs from the research. In the red category, we had 41%, or 15 of those, and they had either dental decay, gum disease, root stumps, pain, or dentures that were cracked or needed replacing. The good news is the orange with some help can become green, and the red with referral can become green as well. So it's an area, it tells us, it gives us data, it's data driven, of what the need is and what can be done. Okay, now the impact. It was really interesting. When we started the research, it was the residents and the family members, they wanted education sessions. They asked for them. So we adjusted the research project and we delivered education sessions to the residents. That was fantastic. We did had an input into the monthly newsletter for the aged care home, which also was requested. There were no issues at all with the residents and the staff using the Smilo.ai app. It was cost effective, it was safe because it could be done in their own homes, and it was a data-driven screening tool. Interestingly, a lot of the residents wanted to purchase better dental products and aids, and the aged care home is reviewing their supply of products and aids after the research. We've also written an oral health policy for the aged care home because it didn't have one. The Smilo.ai app has been customised because there are a lot of people with dentures, and so it has to be customised for the people with dentures. And we also had to get together a better storage and retrieval system for the dentures and the photos of the natural teeth. The ethics process was very long and involved. I think that took 8 months to actually go through Uniting Care. We were the first research project in any of their aged care facilities here in Queensland. So because we were a first, it actually took a long time. Also with the University of Southern Queensland, our partnership agreement also took 8 months. I don't know why it took so long, but that was very difficult and we got there in the end. And again, the data that we're seeing is evidence to say that we actually need a dental scheme for seniors. People do need dental treatment, and the data from here further gives weight to those lobbying and advocacy work. And we've got some other data, the resident surveys and case studies we're still analysing, and also the staff surveys. Okay, now the takeaways is oral health is very important, and as it contributes to overall health and well-being. People with poor oral health are at higher risk of illness, hospitalisation and death. We need to recognise the social determinants of oral health and incorporate a trauma-informed approach here for oral health. And we realise that in aged care, people are entering aged care not with just years of neglect, but decades of dental neglect. For community service providers, for people online today, I think my call is for you to also have a look at your policies and see what your policies are about oral health, about if you need any upskilling of your health workers to improve their knowledge and skills in oral health care, and also what products and aids you might be giving out for those people in your care. I think that the artificial intelligence apps like Smilo.ai could be utilised in other services, whether it be in for adolescents or the young people receiving in out-of-home care, Indigenous groups, etc. I think it has a lot of possibility there. And also my last point about this research does give us more evidence for why we need better dental services. There are references available which are in the slides, and I'm open to questions. Thank you very much indeed. Will I stop sharing?
Thank you, Leonie. Yes, I'll just share our slides now. Were there any questions for our first three speakers? All right, in the interest of time, I will introduce our next guest speakers now. So welcome back from the break, everyone. We will now hear from Trent Carberry, who is the Group Research Lead for VerityView, a group of Queensland disability support organisations. Mr. Carberry is also Adjunct Fellow within the School of Education, University of Queensland, and through this role he has been involved in several disability-centric research projects, including a previous study on disability direct support worker wellbeing and several other projects related to quality positive behavioural support practices for people with intellectual disability. And then we will hear from Dr. Shane Boris Pointing, who is the founder of Fractal Cairns Science and an agent of the Cairns AI Hub at James Cook University's Ideas Lab. With a PhD in realist evaluation and extensive experience across domestic violence, youth justice, healthcare, academia and policying, Shane has led and supported numerous multi-agency projects focused on crime prevention, youth wellbeing and community safety. He is deeply engaged in applying complexity-consistent approaches to address marginalisation and foster collaborative solutions. So I'll pass it over to Trent now to share his presentation.
Hi, hopefully everyone can hear me and can see the slides.
Yes, perfect.
Excellent. So, my name's Trent Carberry. I'm the Group Research Lead with the VerityView Group. And the VerityView Group is the name for a group of disability organisations that are sort of like under one umbrella. And we have the brands that you're probably more familiar with. Multicap is largely focused on intellectual disability. Open Minds is mental health. All Into is our support coordination group. And Arborwell looks after accommodation. And within this group of companies, I'm the group research lead. And this is a relatively new position, started back in 2020. And basically, I have a background in doing road safety research with the QUT School of Optometry. I've also done a bit of research around archery. And my job within the VerityView Group is very easy. I only have to do two things. I need to read and I need to write. So, reading. One of the key factors within a disability and mental health organisation is developing evidence-based practice. And so what you can see up on screen at the moment is this idea that anything we do, we want to have a chain. And that chain starts with working out, okay, what are we trying to deal with? We go to research, we say, hey, is there a current understanding of best practice? Is there anything else we need to know about this problem? This goes on to specific expertise. We have advisors who deal with mental health or physical health. This then goes on to writing policies and procedures, which are then progressively audited as time goes on. So as well as sort of dealing with those, ongoing strategic issues, I'll also provide the organisation with research around things like specific questions that come up in the course of supporting an individual. So just as an example, one of the very first things I was ever asked about was, hey, do we know anything about lead poisoning? Because we had a customer who was being exposed to high levels of lead, who had been exposed to high levels of lead in their childhood. And so I was like, hey, do we know anything about that? What effect does that have on an individual? Just fun piece of trivia. First thing you learn about lead poisoning is it's useless searching on Google Scholar for lead poisoning, because academics love to put, lead into all their titles. So instead, search for plumbism. And another, taking that as one of the first things I ever looked at, one of the most recent ones I looked at was methamphetamine contamination. If you have a customer who uses methamphetamine, is that environment safe for support workers to walk around in afterwards? To what extent, are we dealing with secondhand smoke, but from meth? So those are the sorts of questions that pop up from time to time, so I deal with those. Writing. As well as looking at other people's research, we try and do some of our own. Up on screen, you'll see a couple of QR codes that will take you to two of our more recent papers. And so the idea is that we need to look at the programs that we are doing and work out, hey, are these programs working? Are they delivering the outcomes for customers that we need them to deliver? And this is where I do a lot of work with the University of Queensland and other partners to then publish those results if we think they are of benefit to the wider sector. So just going through a couple of those papers, the complex behaviour forum. So people with disability can exhibit challenging behaviour. And what do we do when we have challenging behaviour? Typically within Australia, the NDIS talks about positive behaviour support. So that idea of, hey, this person is throwing things, or they're screaming at people, or they're hitting people, or whatever. Why are they doing it? We'll conduct a functional assessment. Is this performing a function of escape social? Are they doing it to get away from, like non-desired people? Is this, performing a function of, access tangible? Are they doing it because they know when they do it, they get their iPad? Once we have a functional assessment done and we understand why they are doing the behaviour, we then come up with a support plan to try and teach them more functional ways of dealing with, like getting the result they need. Certainly within Multicap and Open Minds, all of our plans are scored against the BIP QE2, and no plan that is not rated as good or superior ever gets out the door. We have fairly strict quality control regarding our behaviour support plans. And then we have to go on and train our support staff in how to implement those plans. That's what happens for a normal PBS customer. What happens with very complex customers? And for very complex customers, they might end up being referred to the Complex Behaviour Forum. So the Complex Behaviour Forum was inspired by the Multiple and Complex Needs Initiative from Victoria. And the idea is it's a multi-system governance mechanism. So it's a case forum. We sit down and have a whole bunch of people from different areas of the business talk about people who have very complex, challenging behaviour, and try and say, hey, what do we have in place right now for them? Why is it how is it working? How is it not working? How can we improve it? And this sort of provides a level of oversight and helps review what's going on with people and comes up with solutions. Two types of customers appear in the forum. You have people who might be in the forum for a long time. These are people who have long-standing complex behaviour issues and just need that heightened level of oversight just to help them through month to month. We know that some people are always going to have significant levels of complex challenging behaviour, and we need to just provide that additional level of oversight over those individuals. Other times we might have people who are only sort of experiencing a short-term problem. So, and getting back to our previous talk, sometimes that might relate to things like dental pain. So we know that things like that can lead to complex challenging behaviour. So just having a high level of oversight over a person for a brief period of time can tell us, hey, this person might have something complex going on with them, and we need to sort of look at them in detail for a brief period of time. Once we've dealt with the immediate crisis, then hopefully we'll see a reduction in that challenging behaviour. So we thought we needed to review the complex behaviour forum because at the end of the day, it's really expensive. If you take a bunch of senior staff out of operation for 2 days every month, we worked out that it costs at least 60 grand every year to do this. So if you're spending 60 grand, you'd probably want to get something for it. So how do we know it's working, and how do we measure the impact of challenging behaviour within an organisation? So one of the things we looked at was staff injury reports. So the idea was to say, hey, if we know how often staff are being injured in customer behaviour incidents, that tells us that that's a direct cost to the organisation relating to complex challenging behaviour. So we looked at staff injury reports from 2018 onwards, and these are all linked to the customer behaviour incidents that caused that injury. And we reviewed 781 incidents. We also looked at, in detail, 15 individuals who were within the complex behaviour forum, and 15, and we'll call them controls for the sake of this is how we talk about research. Realistically, they were not controls. They were treatment as usual, because all of the control participants were actually receiving our standard level of PBS support. So the 15 complex behaviour individuals were receiving that, plus the complex behaviour forum. And so we wanted to know, hey, is the complex behaviour forum making a difference? Is it helping with levels of challenging behaviour? And what we saw is our treatment as usual group improved over time, which is what we would hope to see because they are receiving positive behaviour support. But our complex behaviour forum group, who were exposed to a higher level of supervision and oversight, exhibited a greater degree of behaviour change. Just so you know, the data within that graph has been standardised. So it all got converted to Z scores and then analysed, just because typically the rates of behaviour are much higher for that complex behaviour forum group. So that's what we wanted to see. So the other paper that you might be interested in was related to the Royal Commission. And as part of the Royal Commission, there was a paper released that looked at restrictive practice and is it possible to eliminate restrictive practice completely in an Australian context. The paper was written by, the primary author was Dr. Claire Spivakovsky, along with Aspro Steele and Aspro Waterwell. they looked at 4 questions related to restrictive practice, with the third question being about, hey, does positive behaviour support work? Does it reduce the use of restrictive practices? And as an organisation that uses positive behaviour support, we were very interested in, what they had to say about that topic. The quick summary is they were not happy with positive behaviour support. And so we were like, okay, well, that's interesting because we think it works. Why do they not think it works? So we want to have a look at that in more detail. And they said that the evidence for positive behaviour support relating to reducing restrictive practice was mixed or inconclusive. Okay, well, we went and looked at some of the research related to PBS, and there is research to suggest that PBS doesn't always work. But what happens when you look at it in a bit more detail? And what you find are papers from people like Hasiotis, McVilly, and Wardale suggesting that if you write bad PBS plans, you end up with bad outcomes. When you look at papers written by McLean, Gray, Webber, and Crates and Spicer, they focused on plans that were well written. So going back to that previous idea that no plan within our organisation gets out the door without being rated as good or superior. When you have plans that are rated as good or superior, you tend to get good outcomes. So is the evidence for PBS mixed or inconclusive, or is what it's telling us is that when you do it badly, things go bad. When you do it well, things are good. That seems like a fairly intuitive result. And certainly I think that's where the research actually leads us. So the real problem within Australia is not about does PBS work? The issue is how do we make sure people are doing it well? Because we know that when it is done well, it does work. We know that it's when it's done badly, it doesn't. So how do we ensure that it's being done well? And there are issues in Australia with it being done poorly. So that's the thing we need to concentrate on. It's not a matter of throwing out PBS because it doesn't work. What else do I do? Bunch of stuff. So I've been working on burnout within disability support workers and support coordinators, and surveying those groups and finding out what levels of burnout are they experiencing, why are they experiencing burnout, and is there anything we can do about it? So just up on screen, we've got some sample data just relating to the MASLAC burnout inventory and the levels of burnout that were being experienced by, in this case, support workers. We are planning interventions. The idea is to implement those interventions, and then we're going to redo the survey. Hopefully we'll have made a change in that. And on top of that, we've got ongoing evaluation work for lots of other internal programs. If we think they're of interest, they'll get published. So thanks everyone. Post any questions in the chat.
Thank you, Trent. Shane, are you able to share your presentation now?
Yes.
Thank you.
Thanks, Nadia. And I'd just like to acknowledge the traditional custodians of Gimwe land where I'm based, and also the custodians of all of the lands on which we are meeting today, and that people travel to be here. So thanks. The presentation is going to be pretty quick. The first slide sums up the holistic place-based approach of the model. The next few slides talk about the background as to how the model was developed. It doesn't include the place-based social network analysis because we're short on time. Then a couple of slides after that show what's possible with some of the current tools. A few people have talked about AI this morning. So what is actually available now, including predictive analytics and machine learning around this sort of stuff. And then the last slide is social digital twin, which is basically a virtual replica of a real life system. So we can make changes to different aspects of the system and model the results. So this one sums up basically the whole approach. So any service system, down the bottom, we've got date of contact from the little avatar there with all the different agencies. And on the left-hand side, we've got the running cost as time goes on. Not sure if you can see those discs inside that circle, but emergency department, hospital admissions, mental health, sexual assault services, resi care, YJ, child safety, courts, police, etc. So the model is based on contact by an individual with different agencies. Each one of those service interactions has a cost to it. And so it has that short-term cost benefit, cost effectiveness approach. Because probably like many of us, I've worked on projects that ended because the early intervention of the prevention stuff was someone else's budget or next financial year. So that short-term cost benefit analysis is very, very important, I think. This is amended data from a case study. I worked for Cairns Hospital and Health Service, setting up the youth health model, which involved establishing an adolescent ward, similar to a paediatrics ward, was one big part of it. The other part was around referrals across the fragmented mental health and physical health system, and also NGOs around that mental health stuff. So I went back to the emergency department presentations by teenagers for the previous 3 years. There were 34 kids who presented 10 times or more to the ED in 2 years, and those presentations, most of those presentations were for, the presenting codes were for problems that indicated abuse or neglected home. So yeah, there were 34 presented 10 times or more in 2 years. There were 22 who presented 5 times or more in a year. There was one young woman who was 15 at the time who presented 75 times in 8 months. So I went back and tracked every contact she had with the hospital and health service since birth, which is basically these things here. And I won't go into it, the red triangles at the end, when she started offending, and all of this stuff was presenting to the ED some days 3 times in a day. So she'd come in the morning with a paracetamol overdose, come in at lunchtime with a knuckle injury, presumably from the fight, come in at night with mental health issues. She'd be seen by different treating teams, go to different databases. This is before the integrated medical system. And there were 3 clear intervention points that were missed. One where she was referred to a Kim psychiatrist by her school guidance officer. This one here was where she was brought to the ED by police following a sexual assault. She walked back in on her own 2 feet the next day, and then the police brought her back in 3 days later because she'd taken some knives to school to have a talk to the boy who assaulted her. Dropped off the radar until coming up to the anniversary of the sexual assault. The red lines is when she was admitted to hospital. The blue lines is when she was presented to the ED. Red triangles is when she offended, and she was brought by ambulance, police numerous times. I did meet her, and she gave me permission to share this story. Her life trajectory was on the up because of the Queensland Health Adolescent Mental Health Nurse Navigator, Dr. Richard Lakeman. So the intervention basically was sharing that information as widely as I possibly could. And this is the monthly number of emergency department presentations. So from February, put that together. And I will frankly admit I've never been as angry as when I put that together, ever. So once people started getting the holistic picture in mid-October, you can just see she got some effective coordinated care, and they just trended down. Number of presentations per month trended down and down. Similarly in Logan, this is, I was involved in the Logan Integrated Care Team, where Youth Justice, Aboriginal Community Health Service, Brisbane, Child Safety, 2 Kim's psychologists, and an education re-engagement teacher with heavy involvement from the police because those absconsions from resis. So I set up a assertive outreach team with a key caseworker model, and this again shows the effectiveness of some of that collaborative care, because this is the previous 12 months. She was an Aboriginal girl. The Aboriginal community health worker started working with her on the 27th of January, and these presentations to hospital were appendicitis and I think dental as well. So that's the total monthly number of contacts this client had with all the different service agencies, well, many of the different service agencies in Logan, which is a accumulation of all these different ones. So we've got suicide alerts, hospital, arrest, offended, YJ on all of these dates. And for each one of these different types of contact with the service agency, you can assign a cost, basically. So depending on the triage level of an emergency department presentation, at that time they range between $750 for a really low priority up to $1,200 for an urgent life-saving presentation to the ED. So she cost the system $141,000 in the previous 12 months. So moving into how that has informed the current model that we've got. It's that timeline idea again, and the different down here, not sure if you can see it, but the different agency types: health, police, court, YJ, education, etc. These are the different points of contact with different service agencies, which each have a cost, and so that we can start calculating monthly costs. And it's also a proxy. If our interventions are working with these kids, they should have less frequent and less severe contact with any of the agencies as well. So it parallels and provides a proxy measure for the effectiveness of our interventions. And it's that short-term cost benefit, cost effectiveness focus. So that is what we've got now. And we're starting to work on the predictive analytics. There's two key parts to this. One is retrospectively identifying missed early intervention opportunities, which will then allow people with some courage, I guess, in that place-based system to collaborate and say, why did this not work at that particular time? And the other one is, again, based on the timeline, according to all the research around this type of cohort and also some empirical evidence about that particular individual or cohort's previous contact along the timeline, we can then predict what would happen with no intervention. And that's, fuzzy, but as it goes on, we get more refined. And then up the top, we measure what actually happened here, which then total cost since intervention and forecast and incidents as well. And that incidents one is really important to me because it's that whole re-traumatization and re-triggering every time a kid goes to tell their story to another, or anyone goes to tell their story to another service. It's just a re-triggering. The social digital twin, basically digital twins have been used for a number of decades for really complex manufactured systems, things like aircraft, Boeing 737s. Maybe that's not a good example. Anyway, in this animation, the doors don't fall off, but we started building this last week as well. And I'll let it speak for itself, but it's just an example using West End, suburb of West End in Brizzy as an example of what this side of the tool will do. So as always, we start with country, layer the built environment over it, drop down the different agencies. And here's your buttons up on this side, and then modelling the journey of a person or a cohort through the system as well, and what has actually happened with them. Then adjusting some of the settings, so making some changes to our own agency that we're in, and that's the monthly cost, etc. But then also those systemic settings. So what are the dependencies among that place-based system that have an impact on the effectiveness of care for these young people? So then we can make some modifications to the system stuff as well. That real-time information sharing, scan panels for me are the real use case. People can actually do this online and see what changes have been made as a result of that without actually experimenting with real people. And that's just some sales stuff. And that's my contact details. So, and that's it. Any questions?
Yes, we'll move on to questions now.
Thanks, Naja.
Yep.
Yes, I've got a question. Sorry.
Yes, Leonie.
I'd like to know how you, what your intervention was for the dental problems.
Very good question, thanks. And as you said, it's such a crucial part of overall health, and it's a real indicator of social determinants of health. So thanks for that as well. Nothing specific, to be honest. That was a key caseworkers thing to make sure they met their appointments and, you know, just talk with them and do that counselling stuff. But yeah, it was, my part in it was that very holistic. So I don't have any details on any ongoing dental interventions. Yeah, thanks.
We did have one question in the chat that Trent also replied to, but it was, what are some of the planned interventions for the presentation from Trent? You did answer it in the chat, but would you like to say anything further?
Sure. So yeah, just that idea that what we found from the survey was that we did get very different sources of stress for both the support worker cohort and the support coordinator cohort. And so that means that the intervention has to be different. So for support workers, a couple of the key issues were around teamwork and challenging behaviour. Now, we can't make challenging behaviour go away. Yeah, not magically anyway. We can work on it slowly with PBS. So the idea was making sure that people have the correct attribution for challenging behaviour, because we know that if you don't correctly attribute challenging behaviour, it can make you, it can change how you perceive it. So if you know that challenging behaviour is a response to an unmet need, that can help you understand that, okay, what I need to do now is explore that need and work out how I'm going to address it. For support coordinators, the thing that came out was often dealing with bureaucracy was a big deal. And that's a problem, because dealing with bureaucracy is one of the key factors in being a support coordinator. They're working within the NDIS. And so it's a matter of having enhanced supervision and making sure that they're dealing with those issues in an appropriate way. One of the key issues that came up with support coordinators was that, by definition, people who work in the disability sector tend to be caring individuals. There's lots of places they could work. They worked in a place where they're helping people. And so we need to make sure that they're not getting super stressed out when that help goes awry, or when they've done everything they can and things still didn't go to plan. Because that is a reality of support coordination, is you can do everything you can to support someone, but the system can still let you down, and that's not your fault. So helping people, work with those issues through enhanced clinical supervision. And like I said in the chat, one of the things we do have on our side in that case is that we do have a couple of psychologists working within our positive behaviour support team who are contributing to that effort. Thanks.
No, thank you for answering that. We do have another question in the chat from Jeanette. I'm not sure which of our speakers she's talking to, but I'll read the question out and hopefully we can figure that out. It says, thank you for focusing on this crucial element of care for those that are not getting the care that they need despite attempts to do so. It must be fulfilling and initially heartbreaking. How can we get involved? It's for Shane.
Yeah, thanks. You're definitely right about the heartbreaking stuff, Jeanette. But I guess like all of us, that's what drives us to do this sort of stuff. Yeah, give me a call or email me. Shane, SHANE at plaict.com.au. And it was just pointed out to me 2 days ago that the ICT in it doesn't actually stand for Information Communication Technology. It's place-based attributable incident costing tool. So yeah, that'd be great to hear from you. Thanks.
We will share all details of our guest speakers in the post-event email as well. So you'll have multiple points of contact. Amy just shared Shane's email in the chat now. So if there are no more questions now, again, just post them in the chat and we can always follow up with our guest speakers. I'll just move on to the next part of the session, which we will just be posting a poll in the chat now. We'd love to hear feedback about the session and how it went. If you could participate. Thank you. Just pop that in the chat now. It's a SurveyMonkey link. Thank you. So while everyone's filling out the poll, I'll just run through a few final things before we wrap up the webinar. So in terms of the Research and Evaluation Network membership, network meetings and webinars are open to everyone as they're about sharing resources and collaboration. However, social service staff in research and evaluation roles are particularly encouraged to attend. Our aim is to deliver a community of practice that promotes collaboration and sharing of knowledge in relation to evaluation methodologies and outcome measurements for community services. Our network adopts a strength-based participatory focus that leverages, draws on, and values current knowledge, expertise, and capabilities that exist within the sector. And as a friendly reminder, we also have the Research and Evaluation Forum that sits within the Microsoft Teams platform. The instructions on how you can join will be in the chat. The idea behind the forum is that we're providing a space and an opportunity for our network members to collaborate, exchange ideas, and also to access professional development opportunities. It's one way to stay up to date with the news about the networks as well. And another reminder that you can access our research and evaluation webinar recordings from the past and all other resources on our Community Door Research and Evaluation Resources page. The link will be in the chat, and once this recording has been edited and shared, it'll be online on that page as well. So just to save the date for our April Research and Evaluation Network webinar, it'll be on communicating impact with better data. The session is designed for community service staff interested in improving their research and evaluation skills. Jen Riley, the Chief Impact Officer at our community, and Smarty Grants will explore how to balance better data, transparency, and context to drive meaningful change in the sector. We will share the event details to the network when it is online. The QCOSS Quality Collaboration Network also have an upcoming workshop on generative AI for community services. The day will cover key topics such as governance basics, effective and ethical use of AI tools, and introduce off-the-shelf resources that may be suitable for use in community organisations. So based off some really interesting AI talks we heard today that might pique your interest as well, the registration will be in the chat now. QCOSS have also recently connected with Motive Consulting, a Brisbane-based company that offers Power BI beginner courses for not-for-profit organisations. Motive Consulting would like to extend an additional discount to our network members for any bookings made in March. We've shared the course and the discount in the chat. So thank you everyone for staying on the line and engaging in today's session. Our contact details are on the slide and again in the chat now if you'd like to reach out to provide feedback, ask questions, or are interested in presenting at the Research Evaluation Network in future events. Thank you.
Thank you for great organisation.
No, thank you, Leonie, for
Bye-bye.
presenting. Bye.
Bye.
Thank you so much, everyone. Thank you to
Thank
all of our
you.
presenters.